Dr. Victor is a transplant hepatologist here at Houston Methodist, associate professor of clinical medicine at Weill Cornell Medical College. He specializes in liver disease, liver cancer, and transplantation. He also serves as director of clinical research for Academic Hepatology, focusing on improving outcomes for patients with advanced liver disease through research, innovation, and comprehensive multidisciplinary care. Please give Dr. Victor a warm welcome applause.
Thank you all very much. I really want to appreciate that everybody's here on a Saturday, as well as thank the organizers and Dr. Kadali for having us. Today we're going to talk about diagnosis, the journey to diagnosis, biomarkers, the role of biopsy, and the staging of liver cancer. When I thought about this talk, immediately a patient that I can remember her face distinctly at the time of her journey. So today we're going to go through an actual patient that I took care of quite a while ago who was diagnosed with liver cancer. It was a 71-year-old presenting for evaluation of abnormal liver tests after a recent ED visit. It actually is a she that had gone to the emergency department for abdominal pain and found a mass in their liver. She had known about a mass in her liver some years prior, but was told it was benign. She did have risk factors for liver disease that included liver cancer and cirrhosis in her mother. She'd been told she had fatty liver, but in the ER, she was concerned that she might have cirrhosis. She was quite worried that she would be labeled an alcoholic and led with, "I do not drink." These are her past medical history. This is her exam, which was largely benign. So these are an older set of slides, so we'll make it work. This was her exam. They were largely benign. She didn't have any real symptoms. As we've talked about today, liver cancer doesn't really have symptoms. So what was the next step? So they called us. We hoped that we would be Superman, but we really were worried that we would not be able to evaluate it, and we have to worry that we do not want to be like this guy. So I apologize. These are actually my older set of slides, so we'll kind of go talk through what I was going to talk about. So this is a liver ultrasound. A liver ultrasound is a grayscale evaluation that shows a really challenging opportunity to diagnose a mass. So if you look here, you can see that the liver on the left is a gray mass, which I will try to show with a pointer. Here, this is your liver. This is bumpy. This is cirrhosis. Cirrhosis, as you can tell, is subtle with bumps here that reflect this liver here. So it is a challenging mass that we are trying to identify cirrhosis. This is a liver mass on an ultrasound. You can see a subtle differentiation in a circle here or a slight darkening here as well. Why do we worry? Because that mass is actually the cancer that you can see here. This is on a CAT scan, which is the next step for imaging. Why this is a challenge, and I apologize, this was a draft slides that we sent. As a lesion evolves through imaging, the vasculature changes. And as it progresses and gets hungrier, because cancer remains a hungry and needy lesion, it grows over time and demands more blood, it changes the way it looks to us and becomes more arterially than vascularly fed. So as it moves into an arterial growth, it will change in the way it looks. So when we talk about this, if you look at the top, this is a dysplastic nodule. A dysplastic nodule seen here as it progresses from the types of tumors, you can see they're very subtle. But in a cancer or HCC here below, you can see that as we add contrast, this arterial contrast shows up as a scan. Here we see a sequence of events from a normal liver to an arterially enhancing tumor to a washout to delayed enhancement at the rim. This is how we find the tumor. My two colleagues have shown that there is no such real symptom that we develop. Okay? These are other pictures, and this is kind of the features. So we're going to stop here because the slides here don't reflect the rest of this patient's journey, and I'm going to just kind of talk through a few things that we can talk about. As we went through COVID, I learned to adapt and overcome technologic problems, so today we will do that as well. This patient, at the time of diagnosis, saw us and was scared. Her mother had had and died from a liver cancer, and she had been told that this lesion 3 years prior was normal. She was told to follow up with her local doctor, but ultrasound was not a priority for her because it was told benign. So after 3 years of taking time off from imaging, she saw us and her lesion had changed. The lesion had gone from what they thought was an adenoma to a potential larger lesion. It was seen on ultrasound, and as we talked, it was not able to be carefully characterized. She saw me in clinic and was told that we needed an MRI. She said, "I don't want an MRI. I don't like to be in that tube." I said, "Well, if you were my mother, I would tell you to make it work, because we need to understand if this lesion has changed or evolved, if they've gone from that dysplastic nodule to a cancer." So she endured the 30 minutes in an MRI. She came back to clinic and said, "It wasn't as bad as I thought. It was loud, but it wasn't terrible." And we diagnosed her with a liver cancer. We asked her to see our surgeons, and we checked an entire battery of labs. And this is where we'll talk about biomarkers and where we're going. Her labs had shown no evidence of elevated tumor markers or the alpha-fetoprotein. She had been evaluated by our surgery team and was asked, "What is our next steps?" She was not able to be resected, so she was worked up for transplant. Through this, the patient's journey was, how could this happen? So what happens in liver cancer and why we use imaging, as everybody has said, there is no symptom by which this can occur. So with lack of symptoms, she had her fatty liver slowly progress with mild inflammation that she never felt or experienced to develop very early cirrhosis and a transition of a hepatic adenoma into a hepatocellular carcinoma. She was lucky that she had gone to the ER for abdominal pain, and an ultrasound without symptom had shown a growth in this lesion. She had asked, "Why didn't my lab show anything?" Well, liver cancer does not have laboratory abnormalities that typically show up. She said, "But they checked my alpha-fetoprotein and it's been normal." Now, alpha-fetoprotein for many of us in this room is a biomarker. Biomarker is a biologic signal that says, hey, there's a problem here. Only about 60% of liver cancers have this biomarker, and hers was normal. Now, on the converse, for patients who have chronic inflammation of their liver, you can have an elevated biomarker of alpha-fetoprotein to low levels. Dr. Galati, Dr. Egwim, and I were all old enough to have treated patients with hepatitis C, and chronically their alpha-fetoprotein were elevated without lesions. So it's not that if you have an elevation, you have cancer 100% of the time, but if you have a lesion and it's elevated, that is a helpful biomarker. But our patient did not have that. And she said, "What did I do wrong?" And I told her, and this is why I picked this patient. I told her she did nothing wrong. She had bad luck with a genetic predisposition to develop this. The only thing she could have done different is advocated more for herself to get screening regularly. As we move into, and Dr. Heine and Dr. Hancock will talk about it, better treatments, easier diagnosis, we are still talking about an asymptomatic lesion that develops over time, and the earlier we find it, the better we do. So back to the patient. She had a lesion that was deemed unresectable. So we treated her with a local regional therapy that you'll hear more about the specifics, but that we knocked back her tumor. We evaluated her for a liver transplant, and after successful treatment of her tumor, she waited about, I think she waited 11 months on the transplant list and was successfully transplanted. She is now, in October, will be a decade out from transplantation with no evidence of recurrence. When I asked her before her permission to use her case in this study, I said, "What would you want people to know?" She said, "Don't let benign keep you from being looked at. If you have a tumor or a mass, that you should ask your doctor, are you sure?" And I tell my patients two things. I know only two facts in life. I pay taxes and cancer grows. So if you keep that real and you know that stability is a marker of a benign lesion, that can help you go forward. That does not mean you need a scan every 2 months. That means you need to make sure that no one forgets about your spot, that no one forgets how you feel because there are no symptoms. So in the world today where I had to make changes to my presentation and talk to you more as a person, this is a true journey that the patient needs to be their biggest advocate. We are here to encourage you to think about liver cancer and not stop asking, are you sure I'm okay? With that, thank you all very much.